Warm good morning to all. At the outset, I thank IPCI for the opportunity, and it's an honor and privilege to present this case in front of my teacher, Dr. Rohit Manoj, who taught me the basics of intervention. So, cutting across the stories of a 64-year-old male, no risk factors, underwent a presumed possibly pure Ostial LED stenting way back in 2014. Further details of the procedure was not available to us. Came back recently with crippling angina despite medical therapy. ECG and echo evidence consistent with ischemia in the lateral wall. Underwent an angio outside, showed a tight Ostial Lcx lesion, advised cabbage, family and patient was not willing. He also had mild renal impairment. He came to us for a PCI. So this is the diagnostic angiogram. The typical Achilles heel lesion for the interventional cardiologist, tight ostial circumflex lesion in a peristent milieu in the ostium of LAD. Right femoral axis, 7 French long sheath for extra support, EBU 3O guide, LCX ostial critical disease, and also you find an aneurysm in the LAD stented segment. So all these complexities requiring an imaging in this scenario. With mild renal impairment, we thought of using IVUS. Run through wire and BMW wire in the LAD, again workhorse wires. We presume that the wires were outside the stent struts, and then we image the LAD. So on the imaging, you can clearly see that there is malapose stents. The aneurysm is actually at the distal edge of the stent, leading on to late acquired stent malapposition. You have underexpanded stents in the ostium of LAD. The stents are actually, as expected, extending across the polygon of confluence, across the ostium of Circ into the distal left main. That is probably the reason for the left circumflex ostial disease. You can see actually as you come proximally, the stent is across the polygon of confluence, across the ostium of circumflex. And you also have underexpanded stent in the ostium of LAD and LAD stent malapposition. So first we thought of addressing this stent issue in the LAD. We expand the ostium of LAD with 3.5 non-compliant balloon and a polygon of confluence and distal LM with 4O non-compliant balloon. Subsequently, the LCX was rewired to the stent struts. The struts were sequentially opened with a 2O and 3O non-compliant balloon, and the first kiss was done with 3.5 balloon in LAD and 3O balloon in LCX. After this, we imaged the left circumflex to understand the reference diameters. The proximal circ was 3.5, LM was 4, and the lesion bed was well adequately prepared after the first kissing balloon. So we took a 3.5 into 24 synergy and placed it from proximal circumflex to ostium LMCA and then deployed it. Subsequently, an LM pot was done with 4O non-compliant balloon at 18 atmospheres. LAD was rewired. The struts across LAD was opened with 2O semi-compliant and 3.5 non-compliant balloon, and LCX was post-dilated with 3.5 non-compliant balloon, again at 18 atmospheres. And the final kissing balloon was done with 3.5 non-compliant balloon in LAD and 3.5 non-compliant balloon at circumflex. And then a final pot to LMCA was done with 4O non-compliant balloon at 18 atmospheres with an ostial flare. So this is the final angiographic outcome. About 60 ml of contrast was used. Renal functions were stable. He is kept on dual antiplatelet therapy with aspirin and ticagrelol. We plan to keep it for 1 year. He was discharged on day 3, doing good on clinical follow-up, asymptomatic. This is the final IVUS run. You can see that the stents are well expanded and opposed in the LAD with good stent expansion. The minimal stent area in the LAD is 9.1. In the polygon of confluence, it is 12. This is the LAD IVUS pullback. And this is the LCX IVUS pullback, again showing good expansion and adequate opposition with good stent areas about 8.4 in the proximal circumflex and the LMCA minimal stent area of 13. So this is where we started off with a tight ostial circumflex lesion with an aneurysm in the LAD segment. What we realized that was the aneurysm was at the distal stent edge, probably an hypersensitivity to the polymer, leading on to an aneurysm there and causing late stent acquired malapposition. That aneurysm segment anyway in the final imaging also we couldn't oppose it well, but again the ostium of LAD was adequately prepared and the LCX was rewired, and we did possibly a decay miniculate, reverse decay miniculate in an initial stented LAD segment. So to conclude, respected chairpersons, LMCA bifurcation PCI, especially in a milieu of stent failures, require adequate lesion understanding so as to plan a proper stenting strategy, because you need to offer a treatment strategy which is at least at par with bypass surgery. For this reason, intravascular imaging, especially IVUS, forms a key procedural step. It gives us unique information which gives us insights into understanding how to prepare the lesion well, how to size the stents properly, recognize the post-PCI complications and etiology of stent failures. Probably in a scenario of LMCA disease, renal dysfunction, ostial lesions, IVUS tends to be a superior imaging modality. Possibly with EM guided, better visualization of EM on IVUS, you tend to have minimal stent areas with IVUS guided stenting compared to OCT. In addition, IVUS or any imaging modality also helps us in post-procedure optimization of results, which also goes a long term in improving the long-term outcomes. And in a person with impaired renal function, IVUS goes a long way in reducing the need for contrast and reduces the incidence of contrast-induced nephropathy. Thank you.